Excited to have you here this morning for our Leadership Exchange Live. If you've joined us before, you know how this is going to go. Let me give you a brief rundown in case this is your first time. I am Bridgette Picou. I am the stakeholder liaison for the Well Project. Of course, we focus on women and girls living with and vulnerable to HIV. Part of my job is to work with clinicians and what I like to call standing in the gap between women living with HIV and clinicians to make sure that each side kind of understands the other. Joining me this morning, I'm super excited. I have Dr. Eileen Scully. I have been on a couple of webinars and seen a couple of webinars with her, and she is amazing at explaining things and making sure that we understand them. So it's absolutely my pleasure to bring her on. I will let her tell you a little bit about her. Dr. Scully, go ahead.
Well, thanks so much, and thanks, Bridgette, for having me here today. I am specialized in infectious disease, and then further specialized specifically in the care of people living with HIV. And my passion is on women specifically living with HIV and understanding the things that they need. And I've had the opportunity to participate in many events that either directly with patients or in community sponsored events, and have learned so much about how to do this job together. And so I've never turned down an opportunity to do something like this, because I just think I learn, and hopefully there's some benefit to other people in getting access to information in a different format than just going to your doctor.
Amazing. Thank you for sharing that. And so again, just so you all know how this will work, we're just going to have a conversation. We'll be asking each other some questions. Specifically in this case, we are talking about aging and health screenings and vaccinations, which are a critical part for anyone to stay healthy, but particularly for those of us living with HIV, right? A lot of HIV is maintenance and kind of staying, I think what you call staying ahead of the curve. And so I think we're ready just kind of to jump right in and get to some of these questions and find out how folks feel about screenings, and then see if we can answer some other questions. So my first question is one that as we age, I think becomes more important for women, because of the fact that we start looking at Medicare, Medi-Cal, right? Our insurance kind of changes a little bit. And so sometimes women may be uninsured or underinsured. So if that's the case, are there tests that you would recommend that women prioritize over others?
So this is a great question, and one to which I don't have a perfect answer. I think the first thing I would say is that for people living with HIV in particular, accessing any social support resources that can make sure that your healthcare plan is tailored towards your needs is like absolutely critical. I mean, we just had open enrollment here for my regular job, and I spent, the hour and a half looking at all the different plans and still wasn't quite sure I was picking the right one. And, that's pretty standard stuff. So I think one thing to do is to always check with if you have a case manager or social work support in the clinic that you're using, or if not, in a community-based organization, because there are a lot of subtleties to this that will be different all across the country. So I can say certain things here in Maryland, in Baltimore, where I practice now, there were very different things true when I was in Massachusetts. I was in Boston for about 10 years there. So the first thing to say about that is, number one, make sure that you are talking to someone to understand whether the limits of the plan that you're in are actually limits that you should be tolerating. And, open enrollment is around this time, and then the health plans change in January. And that's a great time to at least revisit what the options are. So that's number one. Number two, as far as what you should prioritize, this is a very complicated sort of balance to make, because there are some tests that are maybe less useful, but are less expensive also. So how do you sort of balance all of those things? And that is where I would say have a very open conversation with your provider and say, look, I have a limited budget for healthcare maintenance, and these are the things that I think are recommended. How should we prioritize those? And sometimes what you can do is you can plan for a year where you spend your deductible down and then, get other tests done within that calendar year so that you can maximize your benefit, and then say, next year I'm going to try to not hit my deductible because it's too much for me. Or to say, it's the beginning of the year, I can't pay this much right now. Can we revisit this in 6 months? So those are just sort of strategic things about navigating healthcare insurance in the United States, which is not something I have figured out, but I think there are some things you can do. But then I think the major thing that is going to guide which tests you should do are going to be your personal risk profile. And so that's going to arise out of a couple of things. It's going to be family history. If you have a strong family history of cancer, in particular breast cancer, for example, then I would never skip mammography or routine breast cancer screening. If no one in your family has ever had breast cancer, and also you have relatives who've lived to a good, healthy old age, so that we can feel like that's probably not one of your major genetic risks, and you were screened 3 years ago, like those kinds of things will come in. And how much alcohol do you drink? What is your smoking history? So all of these things will come into a calculus of what your highest risk things are. And then you can use that to sort of stratify and say, well, I had an aunt and my mom, and like I obviously need to prioritize a mammogram every year, or not. And I think those kinds of discussions have to be very personalized. And I couldn't, say for everyone who's here, well, you should do this and not that, because I think it's just too hard to know. Also, keep in mind there are some screening tests like colonoscopies that if you have a clear colonoscopy, you don't have to do it again for 10 years. And so that's also something you can even budget for and say, like, my insurance will cover this proportion of it, and this is how I will approach like fitting that into my life, because none of these things are easy. And they're not what you want to spend money on, right?
Right. Yeah, that's you bring up a couple of amazing points. Like I remember a couple years ago when I was changing insurance, like my biggest thing was just making sure that my HIV meds were covered, and that I would have a low copayment for those. And I remember being shocked at how much some of the other things cost, and it's because I didn't pay enough attention. So open enrollment, bringing that up is a really great point, and for people to really kind of start paying attention to that. And the next year, I found a broker and worked with a broker, and usually those are free because the brokers get paid by through the insurance companies or what have you. And so that's a really great way to stay prepared and to be up on options and choices when it comes to insurance. So thank you for that. I wanted to highlight that this conversation comes out of a screening tool that the Well Project came up with called the Healthy Aging Screening Tool. And we have a lot of the screenings that women should be looking at as they age over at certain points in time. And it's not exhaustive by any means, but it definitely is something for folks to check out and take a look at. And I'm sure we can drop the link to that in the chat at some point. And then because I brought up HIV medications, this is a question that occurs to me is, do HIV medication effects mean that I should be screened earlier for certain tests, or should that be kind of at the clinician's discretion or a conversation between the clinician and I? Like, for example, bone density screening, right? Like, is that something I should be looking at before 55? Particularly if I've, for example, with our lifetime survivors, folks who have been living with HIV for their whole life, is that a test that they in particular should be looking at earlier than the recommended time frame?
So that's a great question too. And I think, one of the challenges of living with HIV is accepting the fact that you have to take medications in a regular way for a very long time, hopefully. And I think, that is an underestimated burden at times, because we in the medical field just spend so much time celebrating that the medications exist that we forget that the medications exist every single day for patients and people living with HIV, and that's not exactly what they always want. I remember one woman that I met at a Well Project event described it as waking up in bed every morning with her ex-husband, which at some point she decided she no longer wanted to do that. And like just this idea that you wake up with something every day. But setting that aside, medications have now transformed our focus from preventing, like, and your focus in getting your insurance settled is absolutely makes total sense, because that is a critical lifeline to preventing lots and lots of other health complications. So it certainly is, a foundation. But you also are in a position to live a very long, healthy life. And so we want to make sure that we are doing all the other things. So you're absolutely right. Bone density is the one that comes to the top when we think about medication effects. So antiretroviral therapy, in particular, tenofovir disproxyl phosphate, which is TDF in the abbreviations, and used to be in Truvada, or is in Truvada, which used to be a major the antiretroviral therapy that we used frequently. So that is associated with a bone density loss. It's between 2 and 6%. So it's not huge. It's just there, and it's very consistent. And this is about 1 to 2% more than people would lose in their bone density with other antiretroviral therapy, including things that include TAF, which is what is in Descovy. It's a tenofovir different formulation. So for people who've had exposure to tenofovir, so what you're on right now and also what you've been on are what matters. And that's one thing that I think that people living with HIV can bring up to the consciousness of their providers. So let's say you've changed providers a few times, you come in, you're on Biktarvy, everything's going great. And that provider may not know that you have 15 years of having been on tenofovir in the Truvada formulation. And so that's a point for self-advocacy to say, I wonder about my long-term exposure to this. There is some data that switching off of tenofovir will lead to a rise in bone density, so it's not irreversible, but we don't know for sure whether you get back up as high as you would be. So for bone density screening, we do say in the HIV primary care guidelines, they recommend for cisgender women over age 50, postmenopausal and cisgender women over age 50, that bone densitometry is considered, and that's the DEXA scan where they look at the density of the bones. Mm-hmm. If that is low, then we recommend additional screening for causes of this, which could include vitamin D deficiency, could include thyroid problems, could include other things, and then also discussion of lifestyle factors, which include smoking and drinking more than 3 alcohol-containing beverages a day. And so with all of those things in mind, that is a screening that would probably come up a lot sooner for women living with HIV than for women living without HIV, although in general it's recommended for postmenopausal women. So I will say that I have had a bit of trouble with insurance in getting them to cover bone density scans. In particular, actually more so for men living with HIV, because that's even less well charted in terms of their risk. But it is something that you can advocate for, have the order put in, and then get the information in terms of understanding what costs would be and how you can prioritize that in your overall healthcare budgeting, and like what you have both time and money.
Yeah, amazing. I know here in California, at least, there's been a little bit of a shift towards considering it preventative medicine. And so occasionally it'll get covered under that, but all insurance is different state to state. And so, really being aware of what insurance looks like and what specifically your insurance looks like through your carrier, and trying to get in contact with either their customer service or, an advocate or consultant for them really can make a difference for that. I definitely want to save space if you have questions for me, so that it doesn't feel like I'm just peppering you with questions.
No, so I actually wanted to actually take this minute to ask you, like, the way you're asking these questions is very beautiful and perfect in terms of a provider standpoint. You're coming in with all the information and all the things that you have questions about, which is amazing. I'll just say that in my experiences as a patient, there have been times where I've felt, I'd say in particular, like when I was getting routine screened for sexual health, during a period where I wasn't dating someone, or, before I had kids, or thinking about fertility, there are moments where it's actually quite hard to bring up screening. And so I just wonder how you, obviously you work in this space and you advocate for other patients, but do you always feel comfortable with that in your own care settings? And how do you approach talking to providers about preventive care?
I love that you're thinking about the patient perspective. it is not always easy. And I definitely, as I've aged, I've gotten better. And I think part of why I've gotten better about it is just out of pure frustration with the assumptions I think sometimes that providers and caregivers made. Like you brought up sexual health. There is this idea somehow that when women acquire HIV, all of a sudden our hormones stop hormoning, and like all of a sudden we don't want to have sex. Wrong. And so having to advocate for myself in that way has kind of built my chops a little bit. Like that's still important. And then for me, I have always found that the more research that I do on my own, the better prepared that I feel. Um, I love the idea of walking into a clinician's office and not having to bring up these things. But I also know that I'm my own best advocate. And so sometimes if it means being a little frustrated because I have to advocate for myself, I'd rather do that than not get my questions answered. And the other thing that I've learned over the years is not to be afraid to ask for a second opinion. I think that in many cases we get at clinicians and we feel like we're stuck with them. And I don't necessarily like the term firing a clinician, but we can, right? Like you can find someone else to take care of you if you feel like your needs are not being met. Like I don't have to have a friend relationship, but I do want to feel like I can trust my clinician. And so all of those things go into my comfort level with being able to bring these conversations up. And I also suggest for folks that don't have the ability to really advocate like that is bring somebody with you that can. That's acceptable. To have someone in there to nudge you and to remind you of these questions. And then really as we age, I think it becomes more important that we have someone with us when we approach these appointments so that we can make sure that all the bases are being covered and we can make sure that we're remembering everything that we need to remember. So I think those are the really standout things for me that have made it easier to do this. If I had to pick one out of everything that I just said, it would probably be doing my research and feeling prepared. Yeah.
Yeah.
Thank you for that. That was a great question. I felt good answering it too.
Well, and one other thing I'll just say is that I think sometimes if you have this sense that a provider is overwhelmed by your questions, you may be correct. And it may not be about your questions, but about the structure of the clinic and the number of people waiting. And that is a really good time to say, you know what, let's do questions 1 through 4. And then could we have it schedule an earlier follow-up to do the remaining? And please, like sometimes clinicians will think about that. And I think many of us also now do video visits and things like that. Because like, you know what, it takes time out of work and all those other things to go to an appointment. So I'm not going to assume that everyone can just get another whole day off. But I think to be flexible about how information can be delivered and how these conversations can happen, because sometimes there is resistance to discussion, but it's not because the provider doesn't want to do it. It's because of the way the setup is. And we need to do a really good job of making that clear so it's not felt as a personal sort of like being rushed out the door. But I think one strategy about it is like, can we have another appointment in about a month and we can talk about these other issues that I'm concerned about.
Yeah, I love that. And, I worked in an HIV clinic practically my whole entire nursing career. And it really matters to clinicians when they have staff that they can depend on, whether that's their nurse or their MA. And those are also resources that I think get underutilized by patients, using my chart and calling and leaving a voicemail message that maybe the MA or the nurse can pick up on downtime and ask the clinician and then be able to get back to you with the answer. Because sometimes I think we get caught up on how the information is delivered rather than just the fact that we're getting the information. Mm-hmm. I think that matters a lot. We have some comments in the chat. Joe, who's one of our longtime tab members and amazing, she's in India. She said HIV is not covered by health insurance. And so it's really, really expensive. And so not many would know what they have until they have it. And that's a great point. Again, to the idea of insurance and trying to be really aware of what we have and what our options are. So thank you for that comment, Joe. And then I think Cece was bringing up while you were talking about that it's a great point, and sometimes it's hard to see what barriers the providers could be experiencing. And that's one of the things that I really try to stress. Like, we're all human, and there are things that I feel like absolutely need to be improved within the healthcare system. Um, the reduction of stigma around HIV being one of them. But we have to understand that, like you were saying, clinicians are sometimes hampered by their clinic. This 20-minute appointment thing is not the best. And so just being aware of those things sometimes can ease some of the tension and stress around it. Let me jump into another question that's really important to us because of the fact that we serve women across the gender spectrum. And so what advice do you have for women of trans experience when it comes to getting health screenings?
Yeah, so this is a huge challenge. And I think, one of the things that Joe's comment made me think is this idea that things are identified late because of cost barriers. That's also a really pervasive challenge for people of trans experience, in that they are more likely to have, if they have a cancer, for it to be identified at a more advanced stage. And we could spend an entire hour talking about the barriers to accessing healthcare, whether they range from the front desk to the identifiers in the chart to the experience in the clinician's room, and or even to the experience outside of the healthcare setting, and the additional social stressors and challenges that might make it hard to even come and access healthcare to begin with, let alone not having a perfect experience. I think there's a growing understanding of this for people who are fortunate enough to live in urban settings. There are a lot of clinics that have popped up all over the country that are really trying to focus on providing care that is trans-centered. And some of those, including the one I know of in Newark, New Jersey, they have a front staff who is transgender, and just have really sought to make it a place that feels comfortable and welcoming. And so I think from that perspective, again, the strongest tool is going to be research into what the local healthcare offerings are, and to finding a place that has the experience and therefore is more likely to do things right the first time, which is just can be so critical when people are in a vulnerable position. And so to establish that trust and that environment of safety, I think is so critical. And so looking for clinics with experience and clinics that have focused on making this really a priority is one step. I think for people of trans experience, there's a very simple medical approach, which is that you have to screen the body parts that are present. And I think this can be somewhat triggering for people who have moved past their original bodies into their identity. But I think from a pure cancer screening perspective, for example, if you're a trans woman who still has a prostate, that needs to be screened for cancer. And so those kinds of things are best delivered by people with an understanding and familiarity with the trans experience. But I think realistically, that is from the personal ownership standpoint. There are parts of my body I definitely don't like. That does not mean I don't have to take care of them and to advocate for them being taken care of. And unfortunately, that is the case for just thinking about cancer screening. But in terms of other things, there are some things that change with age. And so in particular for transgender women who are on estradiol for gender affirmation, transdermal preparations are really preferred for people over the age of 45, because it has a reduced risk of having cardiovascular or thromboembolic side effects. In that age range, we also very strongly recommend smoking cessation support. And, I will, in all of the struggles of addiction that I have witnessed and tried to help my people that I work with, walk through that addiction to cigarette smoking is one of the hardest, and I will never just sit here lightly and be like, oh, quit cigarettes, but just that is a health priority along with other priorities, in particular in that setting. And then for originally born females who are transgender men, testosterone can lead to increases in cholesterol and also to some indices of renal function that can change. And so for that population, being more focused on how that impacts your risk of cardiovascular disease is also important. So I think really in the number one thing is to find a clinic setting where you feel comfortable, because everything will be improved, whether it's basic current healthcare or preventative healthcare. And then the principle of screen the body parts that you have, it remains sort of the gold standard for thinking about cancer prevention. Does that answer your question?
100%. And it's such a thoughtful, I believe in giving flowers where flowers are due. It's such a thoughtful way to answer the question. Like, I'm used to hearing folks say your native body part screenings. And I love the way that you frame it as the body parts that you have, because it is implying taking ownership. And I think taking ownership of our health is one of the things that is most important for not just aging in a healthy way, but aging in a way that feels good. And so we could put you on a bullhorn and repeat that, because it really is one of the most sensitive ways of, answering this question and having this conversation that I've heard, which just reinforces why I wanted to have you. So thank you for that. Do you have another question for me?
So I do. So I think when you're considering a screening test, what are the questions that you most want to know? So, I mean, I think there's cost, what the follow-up is, how hard the test is, all those kinds of things. And I think we as clinicians often try to preemptively be like, oh, well, this is easy, or this is whatever. But what are the things that actually matter the most to you?
Sorry about that. My camera, I think I nudged my mouse. I think very much the mistrust and distrust historically of women and clinicians, because we often are not listened to, and our concerns are brushed off as being dramatic or hysterical. And then added to that for Black people, the very real rooted mistrust that we have in the medical system is something that I don't think is given enough credit. And so for me, it is knowing that my clinician is taking my concerns seriously, and not just brushing me off, and not just treating it as though it's everyday run of the mill, right? If I'm bringing it up, it's obviously important to me. And so I want to know that they care about my question. And I want them to be able to really listen and hear what I'm not saying, right? Because sometimes my fear may not be in my question, but in the way that it's framed, or just looking at it from a historical perspective. I think it's really important to have the open dialogue, and be open to the idea that just because you don't find it scary or intimidating doesn't mean that I don't, right? If I've never had a mammogram before and all I've heard is how much it hurts, that's going to cause some anxiety. And so I want that question to be answered in a way that alleviates some, that is honest. Yeah, it might be uncomfortable, but this is why it's important, and this is why it's going to benefit you. And on the benefit side of it is, what is the long-term benefit of me doing this? Is it really going to make a difference long-term for my health? Because maybe I don't think it is. A lot of times in, Black families, specifically, if it ain't broke, don't fix it. Right. And so why do I need to fix it before it gets broken? I guess is the, the idea behind it. So I think those are really important considerations for clinicians to remember when having conversations with women about not just screenings, but vaccinations, which is a hot topic, right? Because of COVID and all of that. And so on the topic of vaccinations, um, are there ones that are really, really critical for women living with HIV? Or
So,
should we just really assume all of them are important and get them done?
so this is a really good question. So I think um, there's two things that medicine has ever done that have substantially improved outcomes from our medical care. The first was when an obstetrician noticed that women at the end of the row of beds giving babies were more likely to get infections, and started washing his hands between delivering babies. So that was the introduction of hygiene into providing medical care and understanding that germs can go from one person to another. So that really helped. The other thing that has really helped is vaccines. And because many of the things that we have to treat processes that have already started are useful and successful, but the things that have sort of changed the world have been vaccines and hand washing. But vaccines are complex. And I think part of the problem with vaccines is that for many of the things that come up, there is a kernel of truth that, for example, vaccines do in fact have adverse effects in some proportion of the population. So some people will have an adverse effect from a vaccine. That is true. What we know from the data is that that's very, very unlikely, and that actually your probability of benefit is much, much, much higher. And that overall, your probability of benefit for your children, your grandmother, and all of those, your community. I think sometimes we talk about the herd, and the herd feels like, some guy on TV or the person who cut you off on the way to work. But the herd is also your people. It is your family. And I think that there's two benefits to vaccine. One is we know that in general, on the individual level, they benefit the person, and they also benefit your personal herd and all of the people around you who are vulnerable for different reasons. So those are all the good reasons for vaccines. So now picking and choosing different ones, like again, the hard part, and I think this sometimes gets lost, is like we're like vaccine, and our medical records are like, red flag for this one, they haven't had this one, make sure they get it. The truth is that individuals' risk for different viruses is different, right? So it's not true that everybody needs exactly all the same vaccines. However, in general, vaccines are so safe that we recommend them for almost all people. So for people living with HIV, I think the pneumococcal vaccine is very important. So pneumococcal vaccine, by the way, does not prevent you from getting pneumococcal pneumonia. It prevents you from getting what we call invasive disease. So that's when the pneumonia spreads into the rest of the body and when we really get into a high risk of mortality. And pneumococcal pneumonia is actually the most common cause of pneumonia, even in people living with AIDS, where we would think of pneumocystis or all these other fancy things that are specific to people living with HIV. But even when your immune system isn't working, pneumococcal infection, so just the pneumococcus, it's a regular bacteria that anybody can get, causes very severe disease. So that's one I always recommend and I'm good about following up on. Hepatitis A and B are both easy vaccines to get. If you have had hepatitis B vaccine in the past and were a non-responder, meaning you didn't get a protective antibody, which happens in a portion of the people. I was one of those people because we have to get it for healthcare, and I got it a couple of times in my 20s and never really took. But now we have a new version of that was just studied in a large randomized controlled trial of 600 people living with HIV. And the new vaccine actually works in 100% of people. So that is one to revisit if in the past you had the vaccine but it didn't work. Who is at risk for hepatitis B? Basically everybody. It's pretty transmissible. So if you encounter someone with hepatitis B, you don't have to do that much to get it from them. There are some viruses that are a little harder to acquire, but hepatitis B is pretty transmissible. So it's one that I would consider definitely completing your series. Meningococcal vaccine is recommended for all people living with HIV. The data for women, a little bit less than the data for men, but benefits in both. So that's one that I recommend. But if someone's like, I'm going to take only 3 of these 6, then maybe I'll put that one in the bottom 3. It's a very severe disease. So you certainly want to prevent against it, but it just doesn't occur all that often. So again, that's the risk benefit there. A yearly flu vaccine is definitely recommended. Some years it's not that helpful, right? It depends because we're guessing the strain. So I'm just going to be honest about that. Sometimes it's not going to change your life. But sometimes it works really well. And even when it's off target, it often reduces the severity of the illness. So definitely to consider there. And then another one that I've really been encouraging a lot with my patients is Shingrix. So this is a vaccine to prevent shingles. And especially in those of us who are old enough, kids these days, like they don't even get chickenpox anymore. But all those of us who had chickenpox as a child are at risk for shingles. Shingles can be annoying or it can be totally debilitating, depending on how it comes. And I will also I'm very upfront with patients about this. It is a vaccine that will make you feel bad. Like some people have to take a day off of work, or they get it on a Friday if they don't work on Saturday. It's definitely one that will make you feel bad, but it will not make you feel as bad as unrelenting shingles for 3 months. So these are, again, the risks and benefits, but I'm very upfront with people about that will be something to consider. There's other vaccines we could talk about. There's obviously the COVID vaccine, and the data on whether or not we need every year boosters or not is still emerging. For people who tolerated the vaccine with no problems in the past, it does give you a boost of your antibodies, which will likely prevent you from getting as severely ill as you might have, and also may prevent some of the long-term complications. But we can't be sure about that. I definitely recommend that people are vaccinated at least once with the whole series and consider the yearly update. Hopefully we'll get that all folded together so it will only be one decision to make. And then the last thing I'll say, just because I think sometimes people get a little bit, freaked out about like how many vaccines we have. The truth is that while we have more vaccines now, they actually are much cleaner than, when I say cleaner, they've been narrowed down to so what we're doing with the vaccine is educating your body to recognize parts of a virus. And now we've narrowed it down to maybe one part of the virus or the bacteria, as opposed to having it recognize just a whole mashed up version of the virus, half of that response being unhelpful. So although in the past we gave fewer vaccines, they were much less focused. And so now we're doing more, but we're focusing the responses much more. So overall, I'm not sure that the immune system direction is that much different than it was even 20 years ago when we didn't have half these vaccines. And the one I didn't mention, HPV vaccination. So recommended for less than 26, between 27 and 45, a discussion, and then a lot of insurance company communications, but definitely recommend HPV vaccination for those age groups.
Yeah, amazing. That was so thorough. And so many points resonated with me. Like I was also a person who I had the hepatitis B series 3 times. As a nurse, you have to get it. And I literally had to go through it 3 times. And I actually had made a mental note on my next appointment to ask my doctor to check it just to make sure my immunity hadn't waned, which I think is something that a lot of people are not aware of. Like, if you had it 10 years ago, 15 years ago, then it may be something that you want to ask about just to make sure that your immunity hasn't waned. Yeah. Also around HPV, which, we think is just for teenagers, and that's not necessarily true. And I love the fact that you talk about how the vaccines are more focused, right? I compare it to the idea of different HIV medications targeting different parts of the life cycle of the virus. And so it's really, really, I think, important to know what you're getting into, which is why I'm glad you explained it the way that you did. And also just to err on the side of caution, right? Like if it's really not going to hurt you, does it hurt you to protect yourself? Probably not. So great point. Yeah, great. Absolutely. Andrea Ingram in the comments said, how about the RSV virus?
Right, so that's a great question. So that is recommended for older, so closer up in the 70s. And, if you have specific respiratory weakness, which can arise out of having chronic lung disease or other issues that would make you at high risk for having a complication, then that's one that you could consider. Or if your personal herd includes people who are at high risk of RSV, you could discuss it with your provider to see if it would be appropriate to try to prevent that, so to prevent onward transmission. I'll also just note that I think Andrina also said that she just said last night, if it ain't broke, don't fix it. And I will say, like, I don't know if this resonates or not, but I think, with screening tests, screening is not actually doing something other than giving you information. If the problem is there, the problem is there. The only thing that we don't have is the knowledge that it's there. And so that's a little different than vaccines. Vaccines are actually doing something, making a choice to make a prevention. But you may not feel broken, but if a cancer is growing somewhere, that is happening. And so I try to take like an empowerment approach to that, because it's true, like having a colonoscopy, if you've ever had one, you have to drink all that horrible stuff and poop your brains out. And, it's not like, no one's going to say it's like a vacation, but it gives you this powerful information about whether or not something is there. And actually, if something's there that would turn into a cancer, then that can be removed. And so that's like, keeping it unbroke. So that's my little pitch there. I don't know if it lands or not, but
It does. Absolutely. It does. Right. Like, there is something to be said for, not knowing what you don't know until you know it. And sometimes you need to know those things, earlier, sooner rather than later. So that definitely lands.
But I just also would say, like, I think one of the things you mentioned earlier was like bringing someone with you, and as you go to these appointments, and I think that's also like maybe something I've underappreciated in terms of, if I'm sending you to have a screening test for cancer, like, who's going to be there to if that screening test is positive, and how will, like, and not to bring up with everybody, because some people are just like, okay, give me the checklist, but like for people for whom there's a sort of fear barrier there, like, how can we think about support, or what kind of follow-up, and that might be follow-up from the clinician, saying like, I know you're scheduled on this day, I'm going to call you afterwards to see how it went, and we'll talk through next steps. And even just there being like, when you have this test, you will get a result, and then we will take the next steps. And that's a question I think people could ask. They could say, okay, so if they find something on a colonoscopy, what would happen next? And then develop a plan that feels safer and more supportive.
Yeah. Yeah. So my very first mammogram, they found something, right? Which is terrifying, because they just say something showed up. We need you to come back in. That's a very scary thing. And so, on my follow-up mammogram, they were doing repeat mammogram and then an ultrasound. I took a friend with me, and just having someone to kiki, and share my stress with, who was deliberately trying to take my mind off of what was happening, was such a, not only just a stress reliever during the wait, but having someone for me to potentially be able to celebrate with, thank God that it was okay, right? That it's okay, but also someone who can sit with me that I can lean on in case it's not a good result is so important, especially because HIV is so isolating. And so that's something that I really try to reiterate to folks a lot, is there is benefit in, we talk about community all the time, but a community of two is still a community. And so it's what you're comfortable with, but there are ways to increase your comfort level.
Mm-hmm.
So yeah, absolutely. Good point. Joe says this is a very informative session and thanks us for the webinar. And she's learned a lot of good things, a lot of new things, which I think is, the whole point of why we try to do this. So much of women and HIV is not talked about. We are certainly becoming more visible than what we used to be, but there's still a long way to go. And I think having clinicians like you who are really doing the work and are willing to sit and have these conversations, so that we can get questions to answers, or answers to questions that we don't know we have, is really, really important. Though we have a question in the chat that asks, is it helpful when patients come in with a list of questions written down or printed out? And I know that's a double-edged sword, but I'll let you go ahead and answer that.
No, I love it. And I usually ask to hold the list. because then I can sort of read through it. I can also get an idea of if there's, if it's too much, I can sort of say, okay, I'm going to need you to pick your top 3 for today, and I'm going to schedule you in 2 weeks for a video visit, or we're going to have a phone call to discuss, so I can triage immediately, because sometimes the list is written in the order that it occurs in your mind, but not in the order of the importance or the emotional content. And so making sure you offer people the opportunity to prioritize their list. And and sometimes I'm like, oh, great, these 6 things we can discuss. Like, this is fine. Any order you want, let's go for it. And I'm going to be, getting things ready for you and resources to go. So I love lists because I feel like people can look at them and reflect back on the things that we talked about. They also can not feel the pressure in the visit of, I have to remember all the things, which we all know doesn't work. And so I love it. I guess some people probably don't, but whatever. If it helps you organize, then and as you said earlier, sometimes we have to change things, because they're not working for us. And it's not because you think that someone is not good at their job, but it's just not a good fit. And that's just the way it goes. And people should feel empowered to do that.
Yeah. I just want to remind the folks that are watching to make sure that you do our feedback survey. It just takes a couple minutes, and it really, really, really does help us with programming, making sure that we are delivering things that are helpful to our community of women. And so please take a second to do that. It's up now, and then it'll be up at the end of the broadcast as well. And so, having taken that little pause, what other questions do you have? I love this conversation.
Yeah, no, so I wanted to know what the main sources. So you mentioned earlier that research was so critical to how you, so where do you look for your information? And how does, I don't know, have you ever used ChatGPT? Are you still, I don't, but I know a lot of people are starting to use different ways of getting information. And where do you get yours from?
So, not to toot our own horn, but the Well Project has a wealth of information. And CC Coleman put Google in the chat. And Google is not always your friend, right? Because Google can sometimes convince you that a paper cut is going to send you into the hospital with, a heart attack. Just it's not always. The information is there's a lot of accurate information on Google, but I think people forget to do things like prioritize. Are you looking at a response from 2024, or are you looking at a response from 2002? Because that's not always clear when the searches come up. With ChatGPT, I've never used it. I know a lot of people that do, and I think that technology works when it works, but it's very frightening. There's 2 things that frighten me about AI. One is AI is built on the information that's already there.
Mm-hmm.
And so there's a real possibility that the information that you're getting is biased.
Mm-hmm.
So that's a consideration. And the other thing about it is that it's giving you a ton of information, but how do you synthesize it?
Mm-hmm.
And so I think using it as a starting point to gather information, to take questions with you is fabulous. But I wouldn't argue with a clinician who is telling me something different than what ChatGPT told me, because who has the degree, right? At the end of the day. So I think the way that we synthesize information and process information that we get from AI or from Google or from other resources is a really important consideration. Your mother's cousin's auntie's nephew's niece who has gotten information from their grandmother's uncle's father is probably not the most reliable. And so who we listen to for information matters as well. But I love the Well Project. I love the CDC website. It's very dry on the CDC website, but it is it's a starting point. HIV.gov is great.
Mhm.
There are a lot of really great spaces on the internet that are being created,
Mhm.
niche spaces, for Black women, for Latinx women, for folks living with HIV. And so I think you were mentioning one, that you heard about, and I've used it before, so I want you to talk a little bit about it.
Yes. Go ahead.
Girl Trek, right? Yeah.
Yes. Yeah, exactly. So in thinking about health for older women, so first of all those websites you used are super high quality. So CDC, Well Project, those are vetted, researched, like referenced. You can check, they have the receipts there. HIV.gov, all those things. And, if you can search them and find like, what are the guidelines for pap smears and CDC, and you will get an actual statement that you can take to your doctor and say, this is what it says, is this what I should be doing or not? But I think, as you say, like AI can provide a lot of information, the synthesis, and more importantly, whether or not it's relevant to you as an individual is where you need a sort of clinician to come in between and say, yes, this is what data says, but for you, you're different in these ways, and we have this particular approach to what's best for you. But I think, one of the things that actually is good for everybody is exercise. And so as we were talking about healthy aging and, how women living with HIV should be thinking about what the most important thing to do, if there were one magic pill where you would take it, there's essentially no side effects, but like lots of benefits, it is exercise. There are side effects if you do it too hard and hurt yourself, but in general, exercise dramatically improves a couple of things, including bone density, but also including frailty. So frailty is sort of a medical term for, someone who you just feel like they might fall and break their hip, or they might, not be able to participate in a community event that's a little bit strenuous because they just look like they just are lacking some of that, what I think the word would be vigor, or just that vitality. And frailty is increased in people living with HIV, and in particular in women living with HIV, and occurs earlier in people living with HIV. So one of the only interventions that is shown to improve that is actually regular structured exercise. And so that's easy to say, but how do you actually do that? I have always for years recommended to all of my patients that the exercise that I would like them to do is walking. And walking to a point where they're just a little bit out of breath, maybe it's just a little bit hard to have a conversation, and to do that for at least 20 minutes on most days of the week. Because usually when you say exercise, people see that like, pick heavy things up and put them down, like on the weight machine, and like, great, that's great for him. But like, we all have lives, and those lives have a lot of commitments. But can you park further away in the parking lot and make your walk into the building at work 15 minutes instead of 2? Can you do certain things that just build into your day a little bit more? Take the stairs twice a day in a specific thing, in a specific building, or something that you typically go to. And so the website I wanted to mention was, I heard a podcast, like I think that's what we all do these days. I listen to podcasts while I'm driving and things like that. And it was the founder of this organization called Girl Trek. And it's specifically an organization of Black women, and it's led by Black women. And the founder is just amazing. But there are 1 million women in the United States and globally who are part of this, and their goal is just to walk. And with walking, 90% of the people who were engaged in the walking reported decreases in depression. 28% of them needed less medications than the year before. 59% of them are doing exercise at CDC guidelines, which is 30 minutes a day for most days of the week. I mean, it's really amazing. And it also has a community aspect to it that I think is just so nourishing. And I don't want to be sexist, but I think for women in particular, community is just so important. And as you've mentioned multiple times, living with HIV is not necessarily a way to more community in the United States for women. And so it doesn't have to be the source of community, but finding it however you can find it, I think is just so empowering and health beneficial in like just a really meaningful way.
Yeah. Yeah. I the walking thing, more and more people that I'm associated with on my peripheral are starting to walk more. I have a couple of friends that have gotten the walking pads for under their desk, that I actually see using them, which is super impressive. It makes me feel a tiny bit guilty, and I need to start maybe looking at doing one. I mean, we're sitting at our desks, we're on Zoom, everybody's working from home. And so finding those ways to incorporate exercise, I think, are really more important. I certainly, um, my aunt used to say folks were infirm. And that was her frailty thing. And so that's not my goal for, my 60s or my 70s. I made 52 this month and I feel it. And so definitely exercise is something that I want to jump into and start ramping up. Olivia put in the chat that she likes, we were talking about resources, Be in the Know, Avert is great for fact sheets, and then the Body and the Body Pro, of course, staples. I did not mean to overlook them. I have a column in Positively Aware. So Positively Aware is another magazine that is great for information. Their annual drug guide is amazing. And so I think any of the specialty HIV medications do a really good job of targeting things that are important to us, POS magazine as well. So those are also really great resources. We are getting closer to time. I want to remind folks to do the survey. And I want to give you an opportunity to bring up anything. We certainly didn't get to all of our questions, which I knew we wouldn't, because the conversation gets going and it gets good. But if there are any things that you want to specifically highlight, I certainly want to give you an opportunity to do that in the last 4 minutes that we have.
Yeah, I mean, I think one thing that we didn't really talk about at all, but is hopefully going to be, we'll have more and more information about in the coming years is menopause, and how to experience that and not lose your mind, and hopefully have people feel like, that this is a part of normal aging for women, and that we should understand more things about it. And so I think there are some studies that suggest that there are differences in women living with HIV, but I think many of the experiences are just similar to all women. And this is one case where I think overall there's been a dearth of research. So we just don't have enough data, and we don't have enough treatments. And also, this is another example of scientific communication. So many years ago now, the Framingham Health Study studied the use of estrogen in postmenopausal women. And the results of that were, upsetting and surprising, with an increased risk of bad outcomes. And so for many years, no one was interested in hormone replacement at all. So that was partially, though, a scientific communication problem, because what that study specifically looked at was women who hadn't had a period for about 10 years, who were then started back on hormones. And it turns out that that's probably not a good idea. But during perimenopause, when it's not just that your hormones are nicely coming down in this organized fashion, and it's just absolute chaos in there, that actually adding some hormone can help to smooth that transition and does not have adverse health effects. And so that message was lost in this initial sort of baby with the bathwater kind of situation, where no, we shouldn't 10 years later try to make people look like they're 20 in terms of their estrogen levels, but there's other things that we can do. And so what I would just encourage people to do for that, since obviously 1 minute is not enough time to discuss, is to do some research. There's some really good websites on menopause that I don't have any of them open or available here, but I can email them to the Well Project, that can give you some guidelines-based recommendations for care. And then it's one of those things that, Bridgette, you just encapsulated. You do your research and then you go in, and if your provider doesn't know, they should provide you with a referral to a specialist to discuss these kinds of questions. Oh, definitely. And you've already done this, see?
We had one, but you know what? Your take on menopause, I'm gonna try to remember to attach to the chat a webinar that I saw you do on menopause. I learned so much just in that short period of time, and so I really appreciate your work in that area. Your work around hormones and HIV is fascinating to me. I can't wait to really have a conversation with you about that. And I thank you for bringing menopause up, because it definitely, I am in the struggle. The brain fog is killing me. And so I think hormone replacement is maybe something that I want to talk to my clinician about. And I'll probably need a referral because he's a male. No shade to him because he's amazing in every other way. But he's been upfront with me that this is not really something he knows a ton about. My Alexa is going off. Alexa, stop. So sorry. It's so embarrassing. Um, Nonetheless, I absolutely want to say thank you so very, very much for this conversation. I gained a lot from it. I'm sure folks in the chat did based on the comments. I appreciate your time. Thank you, thank you, thank you. And for being amazing. Thank you.
No, thank you so much. I always uniformly come away from these with more than I came to them. And I am so appreciative of being included. And just, I feel like we're all working towards the same thing, which is better health for women living with HIV.
Yeah, absolutely. All right. Well, we are headed out. Folks, don't forget to do the survey again. Thank you so much. Share the live once the recording is available so that we can each one teach one and help our community. And thank you for being part of the Well Project community. We will see you next time.